Revolution is a very dear meeting to me, and I had the pleasure and the honor of organizing the last three meetings along with my mentor, Dr. Ramshandani. Unfortunately, this year I could not make it to be physically in the meeting for the reasons that most of you may know. It's my pleasure here to start the meeting with a talk about how to start a journey from open to minimal invasive to total endoscopic cardiac surgery. My name is Qasim Al-Abri. I'm a minimal invasive cardiac surgeon and the assistant director of the National Heart Center in the Royal Hospital in Muscat, Oman. I also did my fellowship at Houston Methodist. This picture was on the last day of my fellowship, and you could see Dr. Ramshandani's extreme happiness driving me to the airport, making sure I leave the country as soon as possible. But soon after that, he realized that he missed me so much, and he wanted to come and enjoy some time in Muscat. This picture was taken at the Grand Mosque just near my heart center where we work. The National Heart Center does around 1,200 pump cases a year. We do all kind of variety, adult and pediatric cardiac surgery, and our cath lab facility is also very busy. They do around 6,000 cath procedure every year. I have no disclosures apart from being a speaker for Edward Life Science. And if we speak about how to start a structured program of a minimal invasive cardiac surgery, I think the step one is to have a structured training and a good mentorship. I have done my 2 years fellowship at Houston Methodist with Dr. Mike Radon and Dr. Mahesh Ramshandani, along with the esteemed structural team there, Dr. Neil Kleiman and Dr. Sachin Goel. So basically my fellowship was doing 2 days of structural and 3 days of minimal invasive and adult cardiac surgery. And I do think catheter-based skills are very important, not only for minimal invasive cardiac surgeon, but for all modern cardiac surgeons. This fellowship has started 2 years before I joined. Dr. Moritz Weiler Valmolmas, he is a great friend and colleague, started this program, and then followed by Aaron Spooner, and then I was after them. And now my colleague Ziab Khan is finishing his last few days of this fellowship, and we are eagerly waiting for him to join us here at the National Heart Center in Muscat. After this fellowship, when I went back to Oman, the second step is to get and gain the leadership and the team support from the National Heart Center here in Muscat. And I started this by writing a proposal to the administration of the National Heart Center before being part of this administration. The written proposal, I stated clearly my objective and the requirements and the possible obstacles. And also, I clearly stated the expectation and the outcomes from the minimally invasive cardiac surgery program. We followed this with a ground round to all teams at the National Heart Center that include the cardiologist, cardiac anesthesiologists, nursing team, perfusion team, administration, all allied health. And in this ground round, we spoke about, again, what is minimal invasive cardiac surgery, requirement from each team, patient selection and referrals, and we emphasized and we insisted on teamwork and support. Doing those two steps were very crucial, and you could sense that the mindset in both the administration, patient, cardiologist, and surgical team has already started. People start talking about it, administration offer their support, patients start hearing about it, and they start asking about minimal invasive cardiac surgery. And the same thing from the surgical team, you could see they are excited and they wanted to move forward and they wanted to try something new, something non-conventional, I would say. The most challenging step was to getting the inventory and the instrument list. But I did not want to reinvent the wheel. I made it very easy. These are Isabel Gonzalez and Michaela Miller, our good friend and supporter from the Houston Methodist operating room. What I did, I just connecting the nursing team at the National Heart Center to them, and we just copied whatever they have at Houston Methodist here at the National Heart Center, and that was a straightforward move, I would say. The team were very excited the moment they get any pieces. They were taking pictures, organizing them, trying them. And I remember this moment when we get the last piece, which is the Signet clamp, the final building block of minimal invasive cardiac surgery tool. We all gathered and we took a picture for it, and we were basically getting ready to move forward. Team training and preparation was a very enjoyable and challenging experience because our team here at the National Heart Center was completely novice before starting this program. So basically what we did, we had a meeting and we chose 4 members from all the teams: anesthesia team, perfusion, scrub nurses, circulating, and the CSST. We did a group in WhatsApp and we started sharing some videos, showing them the incisions, and we kept getting updates about what we need and what we have got already. Then, when we got all the instruments, we start using them in a single we start using them in open cases. So single shifted instruments in open cases. At that time, we used to do double lumen intubation, so the anesthesiologists start doing them in open cases. Femoral cannulation with imaging, we did few cases. We did not have del nido cardioplegia. We started del nido cardioplegia, and also positioning and nerve blocks. We tried them in open cases, and you could see here we have put one of the nursing members on the OR table, and we have trained his colleague on how to position for minimal invasive cardiac surgery. With all of this, we are doing frequent meeting, debriefing with all concerned team to address their concerns and to answer their questions. With that, we move to the final step, which is patient selection. So I was between choosing straightforward patients or choosing patients that will set the team up to speed from the beginning. So I opted to choose a little bit more challenging cases, and we decided to do them campaign based with a proctor support, and we have chosen various demographies, various pathologies, and all patients were called just a week before the program start, and we have done all the education and the investigation, and we have signed them up for a minimal invasive cardiac surgery. I wanted basically to have more challenges for the team before we move forward, or at the start of the program, to give them the confidence that this program is safe and it's doable, and I want them also to expose their abilities and their skills to support me to carry on the program onward. These are the patients that we chose, and if you look here, we have chosen patient various age, various BMIs, various pathologies, and from every single patient, I had an objective, whether it's to try bicaval cannulation or the setup or the body habitus or the complex pathology, or for example, the patient that had infective endocarditis patient. I want to show the team that hemiplegic patient is the most who benefit from these kind of interventions. So these are the patients, and once we were ready, Dr. Ramshandani was kind enough to fly over from Houston to come help support the program. And you could see this is the first case that we did. Dr. Ramshandani is standing in the back, and the whole team was prepared and as if they have done it before. And we have done 10 cases in 1 week. All turned out to be well. This is the last day of that campaign that we did. We celebrated it with the Omani sweets. After that, during the campaign, actually, we looked at the team dynamics and we looked at the patient outcomes, and we followed up the patient 1 week virtually, and then 4 weeks in person in our clinic. And we had given team feedback to the team. We have collected the feedbacks from the team members and from the patients. Once we made sure everything is good, we have done an extensive media cover to make sure the public knows about this program. And most importantly, we wanted the community cardiologists to be aware about this so they can start referring patients to us. This is the scheme that we have actually prepared on how to start a minimally invasive cardiac surgery program, and we were very proud that we executed it exactly the same as stated in this scheme. With that, after starting that campaign, we immediately continued the program, and we started to work on how to sustain and improve this program. Basically, all these campaigns that we did attracted more patients. As you could see in this graph, our wait list for a minimal invasive cardiac surgery is almost always above 200 patients, despite our capacity that has been increased, the operative capacity that has been increased to accommodate those patients. We started expanding our indication. We started with single valve lesions. Now we started to do 2 valves and coronaries. Also, even more complex patients with poor function, we started to do the minimal invasive cardiac surgery since we have the team confidence and we have the experience. This is the experience of the National Heart Center from the start in December 23 to 25, and after December 25 we have moved completely to endoscopic. We have done 183 cases. Most of them are actually mitral valve repair. We still do good number of rheumatic and aortic valves. All our ASDs, myxomas, and ASDs, myxomas, and mitral valves are 100% done through a minimal invasive approach. The other thing that we improved also, expanding our team. We started with 4 members from every team. Now we have, basically today I would say, all perfusionists, all anesthesiologists, and all nurses can be part of the minimal invasive cardiac surgery. And we have 2 surgeons who are capable on doing minimal invasive cardiac surgery at our National Heart Center independently. And soon we'll have the 3rd one, who's Dr. Ziab Khan, sitting in the audience or in the podium. So it's a good achievement to have. Also, we started to advance our technique in a very, very well organized manner. So as I said, we're doing more than single lesions. We have moved to all percutaneous cannulation. Our cannulation has been 100% percutaneously since December 2024. We have moved from mid-cap to endocap, and we started to extubate on table on selective patients. We no longer do a double open intubation and no rib spreading since long time, and I will state that the reasoning behind that. We start to host team from different countries to come and watch our minimal invasive cardiac surgery program, and we also started to travel and proctor team on starting minimal invasive and endoscopic cardiac surgery. And if any of the audience is interested to come and visit us in Oman, just feel free to contact either Ziab Khan in the audience or contact me directly, and you are more than welcome to come and visit our center and our facility. Despite these small incisions, we're getting really very comfortable doing our cases with minimal invasive approach, just single incision. Patient were doing well. The team dynamic is great. But endoscopic was the target. So in July 2024, we have visited Professor Farhad Bakhtiari in Bonn, Germany, with a gesture from LSI, Reiko, and Bob Arts. And of course, Dr. Ramchandani continued his mentorship to me, so he's the one who organized the trip. I flew over with my nurse from Oman, and we both met in Bonn. And at that time, I could see that endoscopic cardiac surgery is the way to go. And immediately after this visit, I went back and I started the whole process again of ordering my endoscopic tools. A year after that, Dr. Ramchandani has found an opportunities with our great friend, Professor Nermer Garanov in Sarajevo. And we have visited him for 5 days. Where we had opportunities where we could get our hands wet with him, and we could have more closer sense on how to do endoscopic cardiac surgery. He was kind enough to host us and show us all the kind of great work that he does. Not only this, he is a great cook, and I do think that we had the best steak with him in Sarajevo, Bosnia. So that was our second visit, a year after the initial visit to Bonn. And then just a month before I started my endoscopic program, the Smart Cannula from Switzerland invited me to go visit a center in Bad Neustadt in Germany with Dr. Ayman Souda. So I invested also the opportunity to go and watch him doing endoscopic cardiac surgery. And I could tell that most of the setup that I do now is mostly copied from him, because his visit was the closest to my launching of the program. So these were the 3 visits, and while we were collecting the pieces, we moved to nearly endoscopic. We used 2D scope. We minimized our direct vision. We were doing the mitral valve I would say entirely endoscopically using the 2D scopes, but with difficulty, I would say. And we stopped doing the rib spreadings. And at the same time, we start training specific scrub nurse from our team for endoscopic, where basically we are teaching him the setup, the RAM devices, and all the other things that are needed for endoscopic. And December 28th, we were having, it's December 30th, where we had all the tools ready to go. And at that time, I had a mitral valve scheduled for a minimal invasive cardiac surgery. Looks straightforward P2 prolapse. And I thought, okay, this is the time to start. So basically, we decided to do it endoscopically. And I set a very low expectation for the team. I told the team, basically, if we can get endoscopically to opening the pericardium that day, I will be very happy. And basically, we started the case. Everything is smooth. We opened the pericardium, looks great. Put the cardioplegia thing needed is fine. And then we cross-clamped, opened the left atrium, and I expected the mitral valve, put the 2 cords. And before that, I felt that, okay, I was greedy enough, and I wanted to stick to my expectation for the case. So I put down my 3D glasses, and I put my loops, and I wanted to do the annuloplasty sutures with the direct vision. And at that time, I realized that converting to direct vision after putting the cords is not a good idea. So the lesson that I learned from this case is not a good idea to do hybrid, basically. If you want to do it minimal invasive, do it minimal invasive. If you want to do it endoscopic, just stick to endoscopic from the beginning. After this case, I felt that, okay, we have the confidence and we can do it. And the second case was scheduled, was a young lady with, she's 28, with very massive bars in her back that fixed a very significant scoliosis. And not only her body habitus is challenging, her pathology is challenging. And that was my second endoscopic case. The moment I had a tough exposure, I realized that, okay, I'm setting myself for a failure. But then my assistant told me, okay, if you can do this case, you will be able to do all the cases afterward. So basically, what doesn't kill you make you stronger. That case went very well. And since then, I would say for the last 3 months, we have pacing very regularly, doing all our cases. We have transformed into all endoscopic. We have we don't put our loops, 3D glasses, no direct vision. And I can tell you, I used to have neck pain, and after moving to 3D endoscopic, that neck pain has disappeared. So it's another reason to move to endoscopic. The cases that we have done so far is mitral valve repair, mitral replacements using RAM devices, and I'll show you a case afterward. ASDs, myxomas. Myxomas are very enjoyable cases, where the whole team see the way you're extracting the myxomas. And with the smart cannulas, all mitral tricuspid valve repair has been done endoscopically as well. This is a quick case where we used the RAM device for a rheumatic mitral. I put the whole case in 1 minute for all of you to watch. So basically, we start with opening pericardium, and here we put a cardioplegia needle. We bring it through a different incision, cross clamp, opening the left atrium, putting the retractor, and here getting the valve out. And you can see the amount of details that you can see here. And this is the first case that we have done with RAM in Muscat, Oman. And you can see the visibility and the exposure is great. Putting the valve down and tying the valve with the core node device, and then atriotomy closure. And you could see even the way you put the pacer wire, the visibility, you cannot get this with direct vision. So this is just a quick snap on how we set up the cases.